Welcome, everyone. I'm happy that everyone could join us here, and very excited about this webinar. Um, so I'm Erica Moore, Director of Operations at the STAR Coalition, and I'm so excited about today's conversation. Um, I will introduce our panelists in just a moment. But I wanted to take care of just a bit of housekeeping first. First, I want to thank everyone who has supported and amplified our Fueling the Future February program. This National Month of Action was created to recognize something that we all know to be true, that progress in mental health depends on more than scientific discovery alone. Depends on trust. It depends on partnership, and it depends on people, advocates and researchers and clinicians and sponsors and community leaders, all of us working together to move the field forward. So throughout February, we've seen organizations across the country take meaningful steps to strengthen their community engagement, and reduce stigma around research participation and mentor the next generation and elevate the importance of continued investment in mental health innovation. And that collective leadership is what fuels the future. So, as Fueling the Future February comes to a close, we ask that our community take one more important step, and that is to speak up for continued access to treatments for serious mental illness. And we have that opportunity right now because the policymakers are evaluating mental health treatment as part of the CMS negotiating process. And Maria can put that link in the chat. But So it's essential that CMS hears directly from the people and the communities who understand what's at stake here. For individuals living with serious mental illness and their families and caregivers and care teams, continued access to effective treatments can mean the difference between stability and crisis, independence and hospitalization, and hope and uncertainty. The deadline to submit your submission there is this week. So if you haven't already done so, we strongly encourage you to take a few minutes to share your perspective, because every voice matters in this one. And we can help, if we all work together, we can help ensure that families of serious mental illnesses and the importance of maintaining access to treatment are fully understood. Maria, can you also link in the chat? Oh, you may have already linked it in the chat. We did a web page with links and resources, and it includes our submission. So if you only answer one question, it says it only takes 60 to 90 minutes, but you can take as little as like 10 minutes to do this, because we've given you some resources and prompts. And you don't have to answer all the questions. I, of course, took 2 days, 10-hour days to answer it, but that means I did the work for you. Anyway, that link, please feel free, and please, I encourage you all to speak for those that live with schizophrenia and major depressive disorder, because it's harder for them to speak for themselves in this case. All right, so today's discussion, it's very much aligned with that mission, and we're here to talk about leadership, trust, policy, and partnership, and how together we can all strengthen the ecosystem that makes mental health research and treatment possible. So with that, I would like to introduce my co-hosts and outstanding panelists. Katie, do you want to introduce yourself?
Sure. Hi, everyone. My name is Katie Sale. I'm the Executive Director of the American Brain Coalition. We are a coalition comprised of patient advocacy groups, professional organizations, industry partners, and government agencies, all in the brain space. The STAR Coalition is one of our members, Bristol Myers Squibb, one of our members, and we really do advocate and elevate the patient voice for brain health, and including, of course, mental health. So thank you for having me today.
Thank you. Catherine, do you want to introduce yourself?
Hi, everyone. I'm Catherine Campbell. I'm the Associate Director for Neuroscience Patient Advocacy at Bristol Myers Squibb. I support our schizophrenia book of work. and have the pleasure of partnering with Erica and the STAR Coalition and American Brain Coalition and many others in my day-to-day role. So thanks for including us.
Catherine, it might be helpful if you gave a little bit of your background too,
Sure. Yeah.
because you
So
did
I've
come from
been
R&D, right?
Yeah. I've been with Bristol Myers Squibb for just over 8 years. I've been on the advocacy side of the house for the last two. But prior to joining the advocacy team, I spent 5 years at Bristol Myers Squibb in R&D, doing clinical trial data collection and data strategy, making sure that the types of information we were collecting was going to meet the needs for the FDA's requirements when we came time to submit and do our data locks. And prior to that, I'd worked with a federally qualified health center in Philadelphia supporting folks who were experiencing homelessness. So I've got kind of a public health lens, an R&D lens, and now the patient advocacy lens as well.
Fantastic. Thank you. And last but not least at all, and many of you already probably know, Mallory Witham. Mallory?
Hello, everyone. My name is Mallory Witham. I am the Director of Business Development for Pillar Clinical Research. STAR is near and dear to my heart because before coming on at Pillar, I had the pleasure of serving as the Director of Advocacy Engagement with Erica, and just spent many wonderful years working with sites, sponsors, really advocating for individuals that volunteer for clinical research and their families, and also all the wonderful advocacy groups that make up the STAR Coalition. So it really came full circle when I moved to a site position. We have 4 sites, all mainly focused on CNS research. Our bread and butter is schizophrenia. That's where we're most passionate. We love to advocate for our communities there. So really honored to be here to be a part of this conversation. So if anyone has any questions about the site side, feel free to reach out to me after this panel as well.
Great. Thank you. Thanks, everyone. All right. So let's hop right into it here. At the STAR Coalition, we often talk about mental health research as an ecosystem. And in any ecosystem, progress depends on all the parts working together, and that the conditions that allow those parts to function are effective and flowing. So I'd like to sort of frame today's conversation around one core idea, that trust as infrastructure. Sort of is infrastructure. If we think about mental health research ecosystem, the whole mental health research ecosystem as the critical infrastructure, it's shaped by public policy. It's built through the collective work of like the academic researchers, government funded institutions, and industry sponsors. Like BMS, and then it's carried forward by the different mental health research is then carried forward by the research sites and the communities that they serve. And trust is what allows that whole infrastructure to function. So without the trust, the system exists, right? Like we can put it all there, but it can't fully function without or serve the people it was built to help without trust. So even the best science can't move forward without it. And so trust will influence whether someone considers participating in research, whether they remain engaged, whether the community views research as something done with them rather than to them. So today we're going to sort of explore how that's built from national awareness down to sponsor responsibility and then to the site level engagement. So we're going to sort of set the ecosystem with Katie. Katie, you have a unique vantage point at the national level through your work with the American Brain Coalition and your engagement across advocacy organizations, policymakers, and public stakeholders. It was with, by the way, it was with Katie and the American Brain Coalition that I was in DC earlier this month doing that congressional neuroscience briefing. Well, it's that briefing that was through the American Brain Coalition. But so Katie really does have this kind of awareness of that national perspective here. And the policy signals how shape how people perceive brain health and mental health research. So from your perspective, Katie, how does the broader national conversation about mental health and brain health influence whether individuals are opening to participating in research?
So that's a great question, Erica. I would say, let's start with, from ABC's vantage point, we're seeing encouraging momentum. So kind of setting the stage, more Americans are recognizing that mental health is integral to overall health. So that is promising. Greater openness in discussing anxiety, depression, and other conditions, and a growing desire for solutions and innovation. And we just saw that a couple of weeks ago in our briefing, actually. And it creates real opportunity. It creates a broader potential participant pool, greater willingness to engage in dialogue, and stronger public interest in new therapies. But as you know, awareness does not automatically equal trust. And that's the big thing right here. We're operating in a climate where medical institutions are frequently questioned in public forums. Social media accelerates distrust narratives, and influential voices can quickly cast doubt on research legitimacy. And when that skepticism is amplified by recognizable public figures, it has measurable downstream effects. It can blur the distinction between healthy scientific debate and institutional mistrust. And it can create this sort of generalized suspicion toward clinical trials. It can increase fear about participant safety. So across the brain health community, we're hearing that potential participants are asking more skeptical questions. Family members and caregivers are more cautious, and then sometimes even actively discouraging participation. Safety concerns dominate early conversations, and participants want reassurance that not just about protocol, but also about the system itself. Misinformation and distrust narratives directly affect willingness to enroll, retain in long trials, and confidence in informed consent. Mental health, I should mention that mental health research is especially vulnerable because of stigma and the stigma that already exists. When someone is already hesitant to seek care, additional distrust can be enough to prevent them entirely. That's why restoring confidence in evidence-based medicine is essential. And I know that we're all together trying to do that. It's essential for sustaining innovation in mental health treatments, ensuring diverse participation, protecting the integrity of research, and maintaining strong public-private partnerships like all of us do. If public confidence erodes, research slows, and ultimately, it's the patients that are paying the price.
Yeah, that's why the title of our webinar today talks about this pivotal moment, and you sort of like nailed it, Katie, that we have like at this time where we have all this discussion happening around mental health and awareness of mental health, and people want to get help, and we're doing some amazing like things. But on the other hand, we have like this distrust coming from influential places that people can, if they are, inclined to be distrustful, they can hang their hat there. So this really is an interesting time in mental health research, because we have these seas, it's like oceans that are sort of coming together and butting heads, and I guess making it difficult for the research and the science to move forward as quickly and efficiently and effectively as we would like it to. So anyway, as when you think about the current moment, what trends are you seeing? Are you seeing any trends in public awareness or attitudes that could either strengthen or undermine this trust? I mean, are there any like trends that you can identify aside from, the most?
So I think there are some trust is obviously built through consistency, clarity, accountability, and then genuine community engagement. So that's really important. And really just acknowledging sort of the broader climate shows up in very practical ways, for those who are working on the ground. We're seeing that there's obviously communicating clearly about safeguards, explaining IRBs, oversights, acknowledging historical harms without dismissing them. And then meeting skepticism with education too, I think is really important.
Yeah.
And just be willing to sort of meet people where they're at, and then start there and say how far are you willing to go at this point, and accept that, and be patient, I think, as well. I think that's helpful.
Yeah, that's so true. And education is it's such a huge part of it, right? Just having the words out there, having people out there talking about it,
Right.
and educating people on you know what Bethany was just saying. Educating people on, we were talking about her book Awakenings, and just showing that, like, people who live with serious mental illnesses, it's not, there's treatments that you can trust and it will help. So, which brings us actually to Catherine, because Catherine, I know your group is working on a big education project, but as this national climate sort of sets the tone for how industry is going to engage with participants and advocacy communities, um, you know, uh, from your perspective, how do you think about your responsibility, not just to develop effective treatments, but also to sort of help create an environment where participants feel respected and valued and safe engaging with research?
Yeah, Erica, those are all really important points and great to call out. I think it's worth mentioning at first that industry hasn't always gotten it right. We've learned a lot over time, and I think that we have a responsibility to really reduce the burden for participants who may be hesitant or may be cautious about participating in clinical research. We're really committed at BMS to bringing lived experience and caregivers' perspectives upstream because, as Katie mentioned, we understand that trust is built through transparency and consistency. We have a capability at BMS called the Universal Patient Language, and it has this vision that we want to live in a world where patients and caregivers and people everywhere can engage with medical information confidently, regardless of their literacy level or their language or their cultural background. And we understand that the participant experience is shaped by what people are asked to do and also how much of that they're able to understand, because informed decision making is an essential part of this process, especially in high stakes moments and things like obtaining informed consent. The Universal Patient Language was co-created with patients and advocacy groups and caregivers and HCPs to make sure that it was really grounded in science. And we send lots of different materials through our Universal Patient Language team. Plain language summaries of our trials. We're making sure that recruitment materials have gone through the Universal Patient Language team so that people really understand what they're agreeing to and feel informed. In one instance, we applied UPL principles to legal documentations, and we saw increases in patient understanding by 69%, increase in confidence by 31%, and increase in trust in BMS by 18%. So we have seen that this is working, and we understand deeply that even the most powerful medicines can't help patients who don't know about it or don't trust it. So we're really happy to have UPL available. Anyone can use it. We really encourage advocacy organizations to check out upl.org and take these principles and apply them even when they're creating their own educational materials.
Yeah, that's fantastic. And that is a fantastic resource. And so appreciate that you guys are doing that, because that really does speak to how you feel about what your responsibility is in mental health research. What are some ways that sponsors can partner more meaningfully with advocacy organizations and research sites to strengthen that trust, not just, during a study, but also before and after? And I know that you work really hard on that as well.
Yeah, that's a great question. It's important to call out that, like, hearing feedback after a trial is done is too late. Participants deserve to have their voices heard at every step of the journey, and that includes earlier on. We want that to be in protocol development stages. We want that to be not just when it's final, but while it's in authoring, while there's things that we can change about it. And I think what's important is this also needs to be ongoing. So we introduced a program called the Peer Program in 2020, which was designed to really integrate that feedback in a more systematic way, and get that input earlier. And even in the process, we've found opportunities to speed that up and to increase clinical trial optimization. We understand that patients are waiting. This work is very serious, and we need to do what we can to move it even faster than it already is. So through the peer program that we have, we've been able to embed the patient feedback and advocate feedback, because we open a contract with an organization that we can get multiple hours of feedback from an organization like STAR or like American Brain Coalition or other organizations, without having to reinitiate a contracting process. So that's an example of a way that we've operationalized things to streamline for more efficiency, so that we can have that feedback more quickly, and also that we can keep getting that feedback over time, right? We don't want this to be a one-time engagement with our advocacy partners. We really want to be a partner of choice, and we want to make sure that folks feel like they're being heard. In one example of a peer feedback that we got on an SMI study, they were looking at the visit schedule. And, we're scientists, we're all in STEM, and sometimes it can be easy to kind of get blinders on, and not always think about the human component. And in the peer review, we were hearing that, okay, this visit schedule is a little bit arduous. If there's an opportunity that you don't need labs at this visit, could it be done via telehealth? Wasn't something we'd considered, brought it back to the study team. We were able to make that change. And the idea is just like, what can we do to make this a less burdensome process for participants and make them feel like we're hearing them? I think it's a tremendous opportunity for us to build trust when we can not only bring in an advocacy organization, ask the feedback, but then also be able to report back out and say, this is what we did as a result of that. Similarly, we've also had sometimes like things that you wouldn't necessarily think about have come up in feedback, which is exactly why we're doing this. But like transportation and how people are getting to their appointments. That was highlighted as a gap for one of the studies that we were talking with Peer about. And we were able to provide transportation cards or ride sharing vouchers as a result of that feedback. And so we've really embedded that at the foundation of what we do at BMS. And we hope that it's seen externally as well, that our healthcare ecosystem is so complex. There's so many moving parts and pieces. And for a long time, it was the researcher oftentimes who had the biggest voice, but patients have an equally important perspective. Their care partners have an equally important perspective. Advocacy groups, it takes all of us to really have all of these seats at the table. And so we hope that is communicated through these wonderful programs that we have.
Yeah, thank you. I saw Mallory nodding away because she is probably one of the people that's providing that, this feedback in these studies. And but so Mal, ultimately the sponsor commitment and the advocacy partnerships become real at the site level, right? That's where you guys are going to interact directly with the participants and their families, the volunteers. So I know you work closely and see firsthand how that trust is built or lost through everyday interactions. So what does trust look like in practice at the site level? And let me continue. And what are some specific actions, behaviors, or relationships that make the volunteers and the participants feel comfortable and respected?
Can you tell I'm excited to answer this question? I almost cut you off. So I was just really, really encouraged listening to Catherine and Katie, because working with advocacy and sponsors is everything with trust for the site. we can work all day long, but without the partnership of our advocacy organizations and our sponsor partners, there's no way that we could do this. So we all know, and I'm probably echoing a lot of what Catherine and Katie said, but trust is earned and not given, and it can take years to build and a moment to lose it. And so we just make sure our sites really honor that. They honor that they have such a big commitment to our communities. And so I'll go, you know me, I'll go off. So I did take some notes to make sure I stay within our time parameters, but there are a lot of levels to this. So, we work with communities, we work with our providers. That's a big resource for us. We work with families a lot. And then, of course, we work with the participant to gain trust. So there's a lot of facets that we're constantly having to juggle. Not one is more important than the other necessarily, but everything does come down to the participant who is volunteering their time to be in a study. For our sites, I'm sure we don't do anything super special, but, we like to show up for our community members, whether that be providing a lunch and learn, a coffee. We do volunteer days, and that is beyond a protocol. It's beyond a study that we might be recruiting for in 6 months. It's just constant, letting them know that it's not transactional with them, that we really want to be seen as a resource. In some of our communities, mental health resources are scarce. We have advocacy groups you can call, but as far as FaceTime with anyone who really can point you in the right direction, it can be limited. And so we want to be seen as that resource for our communities. We all know that research is not for everyone. There are certain limitations to protocols that would not make every person an eligible candidate. And so we want people to know that we don't care if you're eligible for a trial or not. We want to be here for you. So that's just one of the ways, that we build trust, is making sure that they know it's not a transactional experience when you're coming to a research site. Really, time and an open door policy is the best way that we found to build trust. We invite our community members, our referrals, the families. We invite them to our sites to take a tour, to meet our teams, to ask questions. I think that transparency is really just the best policy. Letting them know what to expect from informed consent to what their visits are going to look like will allow them to take home copies of informed consents so that they can take that back to maybe their spouse or their provider or their loved ones to say, do you think that this would work for me? Do you think this is a good option? And, Katie mentioned this earlier, but not pressuring anyone to make them feel like they have to do a study when they come in our doors, just giving them that time and knowledge that we're here for them. So another thing we do that Catherine mentioned is, we want to eliminate any barriers. So we pick up our patients, we pick up their families, we'll bring them to the site, we provide them with meals while we're there. And that's outside of sponsor constraints. Sometimes it is part of the study and they'll allow us to do that, but we always absorb that ourselves because we know that it's important for people to just feel like they can relax when they walk through our doors. So I think that I'll stop myself there and I'll let you go to the next one.
You don't have to, Mel. I mean, that's exactly what I feel like. That's exactly what, where the rubber meets the road, where you're talking to the people who actually, don't have the trust. You're in the communities. And I know that Pillar does a lot of work within the communities, and long-term community engagement, so that you can, become a part of the whole mental health ecosystem in the communities that you guys serve. How do you think, and this is something that all of us, Catherine and Katie, and you and all of us work to try and engage all of the different parts because we all bring something to the table, right? How, Mallory, from your perspective, could like Catherine and me and Katie kind of support your community engagement and sort of societal engagement outside and far beyond just a research study, but in mental health research in general?
Yeah, I think educating us, we do a lot of education, but we want to be educated too. Sometimes it's easy to get, like Catherine said, it's easy to get stuck in a protocol. You put your blinders on, you have your goals for, recruitment, retention, all the things. And so for us to be able to be educated by our advocacy partners, by our community partners, by the sponsors, sometimes, there are certain things that, yeah, we would love to see implemented in a protocol, but scientifically it doesn't really work out. And so just being able for all of us to sit at the table and have that open dialogue and that feedback, and something that I really love that Catherine, the Bristol Myers Squibb does actually, is they do bring sites and sponsors and or sites and advocacy groups in from the beginning. And so we can have that open dialogue to say, like, this is what we would like to see. And so I think just taking pride out of it, we sometimes get so caught up in the minutia of our everyday tasks that we forget that it takes all of us working together, and the people that we're helping is more important than anything. And so I think just having those open conversations really is the answer to all of it. Engagement is the answer to everything, from recruitment, retention, long-term trust. I mean, engaging all the way around, from the very top to the bottom. And it becomes second nature. All of those things come when you can have those conversations and those relationships. Everything else is just an afterthought that is a nice afterthought. It makes you successful.
That's funny because while you were talking, I don't know if you saw that Joshua, he's on this call, and he said that he has been a client of in Bentonville, and
Oh, wow.
and loves loves going there, and says it's great work that's being done there. So thanks, Joshua. That's
Thank you.
awesome to hear.
We always say that, trust is built with individuals that trust us, and they are really the best source of information for us, but also for the communities, because those are the individuals that have experienced it for themselves. And that's why it's so important to make sure that people have a good experience. We have to be mindful that in a research trial, you may be on placebo. And so you're risking a lot. And we never want to destabilize or harm anyone, but having those open lines of communication and, them knowing the risks, but us truly taking into account their needs during a study. We really honor that. That's a lot of responsibility in our hands.
Yeah, I don't know the whole makeup of all of our participants on the call here right now, but I think it's I love that you are so patient forward, and Catherine, BMS is very patient forward. And I think that that's sometimes missed in a distrustful environment. That a lot of people will say, they just want to be, they just want to treat us like guinea pigs, and that's not the case at all. It's not the case at all. And a lot of times, sites take at their own expense, are helping the clients get there, or get some lunch, at I think that it's important that they're, even if they're not in a study.
Yeah, I think we also have an important job to do here when it comes to closing the loop, right? Like, listening is one step of it, but we also, as industry partners, have a responsibility to then report out and to tell you, this is what we heard and this is what we did. And we recognize that's our role in this trust building process. And trying to be patient with folks who may have concerns about clinical research, or there was mention about feeling like a guinea pig. I think it's important to know that we've got do no harm principles in medicine. And so even a placebo, if that were the case, you're still going to get your standard of care treatment. There's no harming of patients. We've come a really long way in the clinical research space. And we've got a lot to be proud of in that. And also just being patient when folks have questions, just continuing to answer them. We try to abide by those UPL principles, the universal patient language that I mentioned, and make sure that folks understand it at the right level. Can we put it in a graph? Could we put it in a visual? Can we do a depiction in another way so that folks can feel comfortable? Because that's really the foundation of all of this. We just need folks to feel comfortable. And if the decision for them is that it's not right for them to participate in the study, that's great. We want to just help them make the decision that's best for them.
Catherine, if we could take that just a step further, and I'm going to put you on the spot a little bit here, and I apologize in advance. So I know that the sites often, at their own expense, provide for the patients who may come in for a study, but then, don't meet the criteria for the study. So off they go. And at the sites, because they're not part of a study, the site takes that sort of financial sort of responsibility for helping that person, whether it's transportation or whatever. So is there something more that you think that like the sponsors might be able to help with in that? Is that something that you guys even like talk about, or?
It's a good question. I think about it in terms of making sure that sites really have an understanding of like who the patient population is that we're trying to reach in advance. I think about opportunities that sometimes we have to do pre-screened informed consents that might like eliminate or mitigate the effect of that, because you might be able to get that information over the phone or via telehealth or a decentralized way. But I would say that it's making sure, right, if we're explaining to the site what it is that we're who that patient is that we're looking for, is trying to mitigate that as much as we can, and also recognizing that you've got to go through the screening sometimes in order to figure out who's eligible and who isn't. But I would say as well, we're thinking a little bit more about what components of our studies can be done decentralized, to reduce the burden on the sites, to reduce the burden on participants. And, if even if it's still a site, maybe it's their primary care physician, or maybe it's their local neighborhood clinic, or it's some other medical facility that doesn't require them to go to a big university medical center that maybe they have to drive to. So there can be different ways that we try to look for those things, but it's also good feedback, right? For us to hear like there is a burden here if this person is screened and they're not eligible for the study. Giving us that sort of feedback is really helpful as well.
Do you want to respond here, Mel?
Sure. So I think from a site perspective, and going back to that trust, just from my experience, getting them in the office and having them come in is that first level of trust. Doing things over the phone, while sometimes it can feel like it decreases any barriers, if you're trying to talk to someone that might be in crisis over the phone, or they're having an exacerbation of their symptoms, it's not always easiest to get a full picture from the site perspective. Some studies are looking for acute exacerbation. So, for that, we would want them to come in. Now, for our more stable studies where you're looking for someone that's on stable medication, it's an adjunctive, sure, that would be fine. But I think from a site perspective, it really depends on your protocol and the patient as a person, not as, a potential research volunteer. So what their needs are. But I think sometimes, for lack of a better term, sometimes what seems easier and more efficient is actually not for the patient. And so from a site level, we're always willing to absorb the burden, whether that be the time that it takes to pick them up, bringing them to the clinic just to find that they're not, a potential candidate. It's worth it to us, because that's where the trust starts, is that first interaction, bringing them in, talking to them, figuring out what they need. And then from there, we're able to take all of that experience and bring it back to our sponsor partners and say, this protocol, this is what your screening needs to look like. This is what, washout could be. So, sorry to push back a little bit there, because it's interesting to hear both sides, but from our side, definitely bringing them in and going those extra miles are what creates that long-term relationship. And then the providers really trust us. They know that we're advocating for not only their patients, because at the end of the day, we can't be here forever. They can't be in a study forever. They're going to go back in their communities, back to their families, back to their primary care, their psychiatrist. So we need to handle that with as much respect as it deserves, knowing that, we need to be a good part of the ecosystem, giving them the information they need.
It's really good and interesting to hear your perspective too. Thanks for sharing.
So I want this to be a more interactive discussion, and please, anyone else on the call, please do feel free to ask a question or put a question in the chat if you want to hear something specific. If you're looking for something specific from the call, please let us know so that we can do that. But don't think right now that there's any questions there, so I will open it up for everyone here. Um, with All right, so what is one concrete action your sector, advocacy, industry, or sites can take in the next 12 months that would meaningfully strengthen trust in mental health research? I don't know.
I can start.
Okay.
So something that we've identified in our communities is just, and within our workplace, like I said, you get your blinders on, you forget sometimes why you're doing what you do. And so something that we're looking to initiate is a give back day. This actually was inspired by one of the CROs we work with. They do a day where their employees are allowed to take the day, Monday through Friday, and give back to their local communities. And so we heard about this and thought it was a wonderful thing for us to do. And so as a site network, we're going to do that as a team, allowing people to really get back in their communities, share what they do, but really just listen and get information from those that we serve to figure out what are their needs, what are we not meeting, that we could be helping with. So that's something that we're going to be doing in the next 12 months.
Mal, there's one of the other sites that we work with does a paid volunteer day. So if somebody wants to do is that what you're kind of talking about?
Yeah.
That it's a paid day for the research staff to go out into the community and volunteer. And I think that that's a phenomenal. I love that, and I think it would be an awesome. I'm a not to like pick any one group or anything, but I'm a huge fan of the clubhouses, and feel like that's where a lot of people are. You know what I mean? And you can. I just feel like you can talk to people there. So I think that that's awesome that you guys are doing that, and I love that. So I guess Catherine, what do you got? What do you think in the next 12 months?
Yeah, one thing that we're really focusing on is really operationalizing and what we can improve in terms of operations. And we're undergoing right now kind of an assessment in terms of, can we get the numbers for how many peer engagements we're closing the loop for? What is that percentage? And what can we do to get that to be higher? Because as mentioned, listening is great, but if you don't know what we did with it, it can sometimes feel less impactful. And so we're actively working on increasing the numbers of closed loops where after the peer engagement, we come back and we say, this is what we heard and this is what we did, or this is what we couldn't change. To Mallory's point, sometimes there are things that can't be, controlled for, or they can't be changed in a clinical trial protocol, scientifically speaking, and making sure that that example is explained also, so that folks understand we listened, we heard, we did this that we could, we didn't do that, but maybe we did this other thing. I think closing the loop is really where we're going to be focusing a lot of our efforts.
That is phenomenal. I love that you guys are committed to that. Katie I think it's going to be much harder for you to answer this question about what can you do in the next 12 months that would meaningfully strengthen trust.
I know. And I kind of go back to,
so there is that.
I'm sorry.
You do it every day. I mean,
we do it. Right. But I was trying to think of like something concrete. And I go back to this whole thing of like, we keep saying engagement, active engagement, when someone's done, not to be treated as a guinea pig. So like, how about, I love the idea of sort of elevating patient ambassadors who've already, participated. Use that. They, oftentimes it's important for them to tell their story. So whether there's a little community that could be built around, and sort of saying, oh, you've got some questions, I'm going to point you to this person that participated before. They love to tell their, a lot of folks want to tell their story. So I think that could be really meaningful for all involved.
We do have research ambassadors that we work with, and those are folks that whether they have participated in a study or are looking to participate in a study, but they are people with lived experience that Katerina actually stays in contact with them to get their story, because you're right. First of all, people with lived experience generally want to tell their story. They want to share what they're happening because they they know that it's going to break the stigma, and they know what that they're helping, and they want to help.
Well,
Um,
and often they may ask a question that they might be scared to ask of someone else, but if you've gone through it already, they're more apt to maybe ask that question, and it might be something you wouldn't think would be on their mind or that they'd be concerned with. So it's sort of more of a peer to peer, which I think does help.
yeah, yeah, that's awesome. Nicole, do you want to jump in, add something?
Sure, I'll just mention. So, yeah, I'm a caregiver for those who don't know me, of an adult daughter with schizophrenia. So, love
And
what you
an
guys are trying to
advocate and an
do,
author.
and an advocate and an author, blah, 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 things. But, anyways, but in the context of today's discussion, so a lot of caregivers like me are going to be gatekeepers. And I've often looked at clinical trials and other opportunities and gone, I don't know about that. No, not gonna look at that. And so meeting caregivers where they are in places where we are. So it's a lot of online communities and a lot of places where it's online support groups or online Facebook groups or online whatever, these kinds of things, to inform us, to engage with us, to use us almost as a channel, right? Because if we feel comfortable and confident, we're not just going to necessarily tell our loved one, we might tell other caregivers as well. And so it's just a slightly different way to kind of look at the same problem. Just thought I'd mention it just because I personally have gone through this many, many times where I'm sort of like deflecting and thinking, no, 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 but this one looks really interesting. And then of course we ask each other, hey, have you heard about this? Are you going to try this? And we have a whole big text network I text with, whatever, moms across the country every day about this kind of thing. So food for thought.
Yeah,
I
and making sure, sorry, it's such a good point, Nicole, and making sure that you also have the resources that are needed. So, do you
Yeah.
know what an IRB is? Do you know
Yes.
what, often we sort of take that for granted and you don't know that often, right?
Right. And I think it was Mallory was talking about, like you guys might drive someone and feed someone. Well, guess what? I'm normally the driver. And if I've got another commitment for somebody else and I'm thinking, oh, I can't get her there and this and that, there's so many, if there are infrastructure supports to enable the process, that's also extremely helpful. And yet none of us know that this exists potentially, like literally none of us. And I'm probably one of the most informed caregivers in the country. And yet, until Mallory said that, I was like, didn't know. Interesting.
I love that you talked about that, Nicole, because something that we do, and I think all sites should do it. But when someone comes in and they share their interest in a trial, we give them what we call a caregiver form, and it can be a friend, it can be a family member, a trusted, the receptionist at where they get their haircut, someone that they really trust. And we ask them to write that person's name and contact information down, give us permission to reach out to them, and then we do so, and we say, okay, so and so is looking to do a study. We want to make sure you are aware of this. We want to make sure that you don't have any questions, because sometimes that outside third party can really help them feel informed if that's a good decision for them. But that way it helps with retention too. Like some of these studies are long. We want to make sure that the individuals are safe if they're outpatient. So say we can't get a hold of someone, that caregiver is the first person we're going to call to make sure they're okay and close that loop to, whether they decide they don't want to do the study anymore or not. But caregivers also see a large burden sometimes in these protocols. And so having feedback, we really try to take that into account. Can they get them? A lot of times they're working other jobs and a full-time caregiver. I mean, your insight is invaluable, truly. So thank you for being here today and speaking up.
Yeah, of course.
Nicole, you know what, Catherine, I want to give you an opportunity to actually chime in on that one too. I know, right?
I don't know how to follow that up, Erica.
It's such a big thing. Caregivers that
It's like, I think there's been so much interest from our side of the world in our side of like industry, and like how do we engage caregivers. I think that for BMS, especially now that we're in the serious mental illness space, the importance of that. We've absolutely had focuses and gatherings with caregivers and advocacy organizations to make sure that we're listening first. But I'm constantly humbled, Nicole, by you and by your willingness to share, and the way that you inspire other people also to do the same. We hear you, and it's an honor to be able to listen to caregivers and your stories. We couldn't do any of the work that we did without you, and it makes such just a tremendous difference. It like warms my heart.
Well, I mean, BMS is great about engaging with caregivers. So, I know this.
Yeah. I I I see Erica Tingler from Schizophrenia and Psychosis Action Alliance is on the line here too. And Nicole, I know you used to be with SMPAA. So um but yeah, I feel like um caregivers are getting more sort of more play, more attention. Um and people are beginning to understand that without you guys, um there's there you know so many people, so many more people would be you know actually dying. um I and that's not even an understatement. So I wow, yes, I know, right, Catherine? I know, right? So okay. Thank you, Nicole, for chiming in on this. Appreciate that. So maybe you could start us off, Nicole, with this next one. Where do you see the greatest opportunity right now for collaboration between everyone to improve research and the participant experience?
Okay, I actually have something to say about that. Not shockingly. If anyone knows me, I've got an opinion. But here's the reality. Until you are thrust into this space, and I mean thrust, right? As a caregiver or someone diagnosed, you're going about living your life, and then all of a sudden, the wheels fall off the bus. And you're like, what is happening? And so there's a period of time, depending on where your loved one's at, or if you're the one who's diagnosed, where you're just trying to like figure out what's going on. You're trying to get your feet under you. And then one day you wake up and you think, how did they get to this medication? Or, keep hearing these things about this new medication called Cobenfy. What is that? Why do we, and just, it's like kind of on the outer periphery of your world, but you don't know what it means. And then maybe you're lucky enough to be on a support group call and somebody's like, oh yeah, my blah blah is in a clinical trial. And you go, clinical trial? What? Where, what does that mean? How does that work? Oh, I don't think I want that for my loved one. Oh, that sounds risky. Oh, that sounds dangerous. Are they lab rat? Like what? And all of a sudden, a million questions come into your head because this is not a world you know. None of you know. The person diagnosed doesn't know, and the caregiver doesn't know. Nobody knows this world. Nobody. And so maybe a clinician from the outer periphery might suggest it, or maybe somebody might suggest it, but it's like way around the edges of your landscape. And yet there's all these questions. So I think fundamentally helping people, oh, that's stupid, my stupid hands going up, helping people understand what clinical trials are, what research is, why it's important, how it works, how many people go through research trials there's just so much. Even today, I still don't know. And I think just blocking and tackling, helping people understand what this stuff is, how it works, how people engage, like the amount of times things go wrong or don't, or the number of times things are successful. It's just like when you're in my shoes, we don't know anything. And I'd say I largely still don't know anything. And so it's scary. We're already in a dark, scary place because of the illness. And now somebody's going, hey, go put your loved one in this trial. And you're like, oh, I don't know. I don't know how much more dark and scary I can handle. So shedding light on this universe, really shedding light on it so people start to understand what it means. So it's not scary and it's not dark. To me, it's real fundamental blocking and tackling.
I gotta say, almost every single time I'm on a plane and I have a conversation with anyone and tell them what I do, and with and they will invariably say they have a neighbor, a loved one, a relative, or whoever with a mental illness. And I ask, is it being well treated by the medication that they're given? Because the medication that they're given is given because of their insurance or because of a step program. It's not necessarily given that medication because that's what the doctor thinks they should get. It's because they have to, go through whatever processes that they go through. So I always say, you might want to check out if they say that the person that their loved one is not being successfully treated with whatever medication, that research is always an option, right? I mean, if you've got nothing to lose, you've got everything to gain, and sometimes that's where you are. So sadly, how about Katie? Do you is there any place where you see opportunity right now for collaboration between sponsor and advocacy orgs and research sites to improve this for?
So I'm going to take it just a little broader.
Good.
As you know, I probably will. Public conversation, so advocacy, storytelling, but collaborating together to do so, similar to what we've done by this briefing that we held 2 weeks ago, because we had a person with lived experience, we had the professionals, both public, private, partnership, all included with the same messaging, coming at it from different angles, but all saying it's very, very important. And I think just that continued elevation at that level will also just help with the overall skepticism. And I think that kind of coordination is really important.
Yeah, absolutely. Absolutely. Catherine, do you have anything to add?
I think that's an awesome summary.
Well, that's okay because we are at time. So I want to thank all of you. Wow, of course. I want to thank everyone so much for your time and everyone on the call for joining us. If you have any questions, please feel free to, you can always text me. I'm going to put my email here in the, and if you want to get in touch with anyone, I will connect you. So anyone on the call is welcome to, and Katie put her contact info in there. But I can help connect you to Mal or Catherine, if you have a question for them. And thank you guys all so very much. Catherine, Katie, Mallory, Nicole, Bethany, thank you guys so much. I appreciate Joshua. You guys have been great and I appreciate it, and have a wonderful rest of your day.
Thank you.
Thanks.
Thank you. Bye-bye.